This short video is going to be covering the topics of the pelvis, the sacroiliac joint, and the femur. I will just be covering select slides and skipping many of the bony landmark and ligament slides. So first up, as we delve into our discussion as we head into the lower extremity, the first thing that we need to cover is just the articulations of the pelvis. So the first one that we're going to talk about are the sacroiliac joints, and then we're going to talk about the pubic symphysis on the anterior portion of the pelvis. So the sacroiliac joint is the place where all of the weight of the upper body is going to be transferred into the lower extremities. So all of the weight here is going to meet and start to flush into the lower extremities. So we're going to have two joints, one on the left and one on the right, and as the sacrum comes and slides in here, it's going to fit in like a keystone here into this pelvis. So as we move into the lower extremity at this sacroiliac joint, there's not going to be any specific muscle which acts directly on that joint. Rather, we're going to have a collection or group of muscles that will traverse this entire area from the lumbar spine down into the femur that are going to influence this joint and create motion there indirectly. The thing that I really want you to glean from this slide is that the sacroiliac joint is a collection of joints that work together to provide stability to a very critical transition between the axial skeleton into the lower extremity. So the joint has synovial portions, it has ligamentous portions, cartilaginous portions, and fibrotic syndesmosis included all within the joint. The SI motion decreases throughout life. Even when we're young, we have very little SI joint motion, and as we age, we gain even less. Moving now anteriorly into the pubic symphysis, this is going to be a fibrous joint connection between the two os coxa, hence the name pubic symphysis. The ends of these bones are covered with hyaline cartilage and considered a true fibrous joint. I'm going to go ahead and skip through these ligament portions and come here to this os coxa slide just to remind you guys of the three bones that make up a single os coxa: the ilium, the ischium, and the pubis. You can see that the ilium, the acetabulum here is what really creates the dividing points between the three fused bones, with the ilium taking this superior portion of the acetabulum. The ischium is the posterior inferior portion, and then the pubis is the anterior inferior portion. There are some really nice slides as you go through here. I particularly like this one, which helps us understand muscle attachments. And as you guys have been taking these quizzes, a slide like this can really help you begin to understand the attachments of a lot of these muscles. So I'm going to go ahead and skip down, cover a couple slides here. So the thing that I wanted to get at here, so inside of our individual os coxa bony landmarks, we're going to have many of them. One of them in particular that I wanted to show you as we come into this slide is the greater sciatic notch. This is a structure that you were likely just tested on, and you might recognize it right away here, the greater sciatic notch. But the greater sciatic notch, when we put it in conjunction with the sacrum, is going to form a very important space here that is further subdivided by some ligaments that you will see later when we get into muscles. But you can see here that the greater sciatic notch truly makes a space through which things could pass as they travel through from the axial skeleton into the lower extremity. Just a reminder here about the pelvic brim and the structures that help make up the pelvic brim: the sacral promontory, the ala of the sacrum, the arcuate line, pectineal line, pubic tubercles, and into the pubic symphysis. And now we are going to head towards the femur. So the hip joint, I don't think this will come as a surprise to anybody, but this is going to be a synovial ball and socket joint. It's where the acetabulum meets the head of the femur. And I'm going to cruise on through a little bit until we come down here. So I want to just cover these last couple points in regards to the femur outside of the many structural, you guys can go through and make sure you're clear on these lab structures before you take the lecture exam. But I did want to cover something that will come up that you likely haven't seen and you for sure didn't see it on the lab portion. So similar to the humerus and the angles that occur at the humerus, we're going to have angles within two planes in the femur. So we're going to have an angle of inclination, and then we're going to have an angle of retroversion or anteversion, and in the femur's case, it's an angle of anteversion for the most part. So our angle of inclination will change throughout life. When we're born, it tends to be greater, around 135, 140, somewhere right in there. And then as we become weight-bearing, Wolff's law is going to dictate to the bone that this angle of inclination will decrease. In any given individual, we may have an angle of inclination that is greater than, or less than normal. So anywhere between 120 and 130 will be considered normal. If we have less than 120, it's going to be considered a coxavera. You can see how the knees are going to be coming in here. And then if we're greater than 130, it will be a coxavalga, and you can see how the knees would be coming out here. So a coxavera would lead to a knock-kneed condition, and then a coxavalga would lead to a bow-legged condition. But the normal is going to be right in here with 125, well, really 120 to 130. As we move in here, we're going to come into our angles of anteversion or femoral torsion. I want to flip over here to this slide and just try to use this visual to try to help us understand these angles a little bit more. So the femoral torsion angle is going to be the angle that is drawn through the head and the neck of the femur here in relation to the femoral condyles if they are placed flat on a surface. So our femoral torsion angle is going to be our relationship, so how far this femoral head and neck are rotated either anteriorly or posteriorly. I'm going to fast forward just a little bit. So let me come back to our PowerPoint slide here. So our femoral anteversion, our typical femoral anteversion is anywhere between 12 to 15. I wanted to show you this slide. You'll see here on this, they have 10 to 15, so probably just a little bit of a different source, but really 10 to 15 is going to be a very normal angle of anteversion. As I come back here to this slide, I just wanted to show you guys. So if we have an angle that is increasing anteriorly, okay, so it's increasing anteriorly, it's getting larger, so greater than 15 degrees, this will be considered excessive anteversion. And if we are decreasing the angle of anteversion closer to 0 or less than 10 degrees, we consider that femoral retroversion. Although the femur isn't technically retroverted yet, it is just less anteversion, but it is more retroverted than usual. So hopefully this visual here can help you understand that a little bit. So I'm going to slide back to this slide. I'm going to come back to this slide. So if we have, and I'll try to demonstrate this a little bit in class. If we have excessive anteversion, try to think about this in your mind. If we have excessive anteversion, that anteversion is going to have to still fit into the acetabulum on the os coxa. So as that femur becomes more anteverted, the entire bone has to rotate to still fit into the acetabulum, and it will result in toeing in. If we have a retroverted femoral torsion angle, again, try to visualize this in your mind. Our femoral head and neck is now going to be moving posteriorly, but it still needs to fit in that acetabulum, so it will adjust accordingly. And what will happen is the rest of our leg as it comes down will result in toeing out. So our femur will be a little externally rotated, our tibia will be a little more externally rotated, and then our feet will demonstrate that with a toeing out gait. And that finishes this video covering the sacroiliac joint, the pelvis, os coxa, into the femur.